Okay, can people online just confirm that they can see our screen?
Yes, we can.
Great. Awesome. Okay. All right, everyone, thanks very much for coming today. Our speaker today is Maheu-Giroux. Mathieu is a public health researcher at McGill University in Canada. His interests are really in epidemiology, infectious diseases, and mathematical modeling. In the field of HIV modeling, Mathieu is very well known for his work on the HIV epidemic in West Africa. He's also done a lot of work on modeling HIV testing and particularly estimating progress towards the first of the 95% targets specified by UNAIDS. And recently he's also been doing a lot of work on modeling structural drivers of HIV, including things like intimate partner violence and stigma. So today he's going to be talking to us about the work he's been doing in the field of modeling HIV testing. Mathieu, we're very grateful to you for coming here and presenting to us, and we look forward to your presentation. Thanks.
Good.
Do you know how to share from here? It's just like, okay. Great.
Okay, I don't see my notes, but it should be fine. So yeah, thank you very much for the invitation to present and for hosting me for this long month visit. The objective of the presentation today is to discuss work we've done on measuring diagnosis coverage, so the proportion of people living with HIV who are aware of their status, but also some ongoing work about how we can improve the model and where should we be going with these estimates and what are the new challenges ahead. So first I'm going to briefly recap how to measure HIV status awareness or knowledge of status, and then we're going to go on to 4 different projects on estimating trends in diagnosis coverage, but also time to diagnoses, the importance of ANC testing and its determinant, the impact of recent decline in HIV testing on different metrics of testing efficiency, and the potential integration of new testing modality, especially HIV self-testing, because this one would affect the interpretation of the program data. And I'm going to go back to that later in the presentation. So first and foremost, why am I so interested in HIV testing? Well, I think it's the really important point. It has been a bottleneck sometimes for access to treatment and achieving viral suppression. It's also a great way to link people who are at risk of HIV, who test HIV negative, who are at risk of HIV, to linking them to the appropriate prevention measure, whereas it's going to be prevention of mother-to-child transmission or vertical transmission, PrEP, or male medical circumcision. And of course, if is HIV positive, you can be linked to care so that you can achieve viral suppression. So that is the status-neutral approach to HIV testing. If we think about how HIV testing services have evolved over the last 20 years, initially when it started in the region here in the last 2 decades, at the beginning of the 2000s, it was initially provided in standalone sites. So it was it was kind of, you needed to have symptoms or co-infection to be tested. And then with the scale-up of the RT program, it was also, testing services were also expanded at health facilities, and then testing at antenatal care became systematic, and of course now it's complemented through other testing modalities, for example, home-based tests, self-tests, or index testing that are gaining in prominence. So how do we estimate knowledge of status? If you have good case-based surveillance data, so that means that for each new HIV diagnosis, you kind of have a unique identifier, and you're able to know how many people you have diagnosed in your particular region, province, or country. Of course, you need to also have a really good vital registration system, because you want to remove all the deaths from the people that have been cumulatively diagnosed over time. So that is I wouldn't say it's simple, but if you are able to get the numerator, the number of diagnosed people living with HIV, then it's relatively simple. The denominator, however, the total diagnosed and undiagnosed people living with HIV needs to be estimated. So even in a setting where we have case-based surveillance, like I'm not going to show it today, but we've used this approach for the province of Quebec, where I'm native from, and you still need to estimate the proportion of the overall population of people living with HIV, but you can do it in different exposure category, men with sex with men, people who inject drugs, etc. When you don't have case-based surveillance, the biggest challenge is that now both the numerators, or the number of people who are diagnosed with HIV, and the denominators need to be estimated because they're not directly counted. So it's an added difficulty to the modeling. And back in 2017, we had the ideas with Oder that we can improve current estimates of knowledge of status by triangulating information from population-based surveys, such as the DHS, the Demographic and Health Surveys, the population-based HIV impact assessment, etc., and also the program data on HIV testing services. So the number of overall tests that are being administered, the numbers that are positive, as well as epidemic indicators for incidence, mortality, etc. So the first part of the presentation now is some work we've done to estimate that proportion of people living with HIV who are aware in setting where you have biobehavioral surveillance, so no case-based surveillance. As we know, in 2014, UNAIDS put forward is 90-90-90 objective. And at that time, they also needed to have estimates of knowledge of status. So the approach that they were previously using was that you can have an estimate, let's say from a survey, of the proportion of people living with HIV in your country. And often these surveys are accompanied by a question on, have you ever been tested for HIV? So if I'm living with HIV and I've never been tested, of course, I cannot know my HIV status. Similarly, we have a lower bound for the first 95, which is ART coverage, because if I'm on treatment, I'm diagnosed, of course, I will know my status. But then it was in the middle ground here where they needed to make a lot of assumptions. So one of the assumptions that they made was, it's not a bad one necessarily, is to use the midpoint between these two. The problem with this approach is that you need to make further assumptions because, as we know, the population-based surveys are conducted at best at 5-year interval. And we know now that with the withdrawal of US from global institution, the cancellation, for example, of the DHS program, these surveys will become rarer and rarer. So they need to basically project from the last survey and come up with an estimate. It was not necessarily bad, but we thought that we could improve it by, like I said, triangulating different sources of information. So I'm going to make a small parenthesis here and say that for the HIV epidemic indicators, so the estimates of incidence, mortality, ART coverage, UNAIDS has developed a number of tools to help country estimate those. I know that in South Africa you're using Tenvisa, developed by Lee, but in most other countries in the African region, they're using Spectrum EPP. And the basic idea is that you have a demographical model here so that you know how many deaths you are, how many births, age-specific fertility rate. And then you have what's called the estimation and projection package, where you input your surveillance data, so your serial survey, but it could also be surveillance of HIV at antenatal care clinic. And then the general idea, once you estimate these new infections, is that you have a CD4 progression model, and then you can have people on ART2. It looks complicated, but if we think about it, it goes back to the simple epidemiological formula. And that's an approximation, of course, because the assumption is everything is at steady state, and epidemic are not at steady state, but the idea is that the prevalence that we observe, let's say, today in a serial survey is a function of the incidence and the duration of the infection. So the basic idea of spectrum and EPP is that an incidence curve is estimated. So by year, we have the number of new infection based on serial survey, surveillance and antenatal care, and also assumption about the duration of this. And of course, ART coverage will affect this part. So that's why this equation doesn't hold, and we need to default back to the more complicated model. So what we did was to add on a model of testing behaviors to spectrum EPP. This was based on work that Lee performed and published in 2015, I think. And the general idea is that you have people who are not living with HIV, and then they can either acquire HIV or be tested for HIV, and then they've been ever tested. If you acquire HIV before being tested, you're never tested, so that's the upper bound, and it's informed by surveys. If you've been ever tested and then you acquire HIV, you're unaware. And of course, we have this this box here that is people on ART, and if you're on ART, of course, you're aware. That comes in from the program data of all these countries. And the basic idea is that we calibrate the testing rates. And the testing rates are all these arrows except the incidence and the treatment coverage. And we triangulate the population-based surveys with the total number of tests being performed, as well as the number of positive tests. And this is how we can achieve a better estimation of the proportion of people living with HIV aware, as opposed to just making the midpoint between this box and this box in the model. So once we've developed it, of course, we validate it. I'm not going to show you the validation, but if you're interested, I've got more slides at the end that we can go through that. But it's now been implemented in Spectrum, and each year or 2 years, there are workshops held these are pictures from the West and Central Africa workshop for Francophone countries, where country teams come in with their data, and then they use Spectrum, they use the model that I described that we've called Shiny 90 to estimate the knowledge of status. So in 2020, Katia Giga led that work when she was a postdoc at McGill, but also with a lot of help from Jeffrey Eaton. We collected all the projection files, so the spectrum file from 42 countries. And we also triangulated with the 176 population-based surveys that have information on HIV testing. Have you ever been tested? Stratified by sex, by age, by HIV status. It is available in the survey, and these include 2.6 million respondents. We also had almost 200 years of data points for program data to help triangulate that information. So what we found is that there were important increase in testing coverage. So in 2020, it was close to 80% in Southern and Eastern, and it was lower in Western and Central. Western and Central have much lower prevalence than the other region. And it's not necessarily that their HIV testing services are not as performing. It's just that the HIV epidemics are more concentrated in key population that might have bigger unmet testing need. Women are more likely to be diagnosed than men. And for if we look at stratified by age, we find that people in the youngest age group, 15 to 24, were the least likely to be diagnosed. For this last result, I'm not quite sure that we can interpret it as young people have unmet testing needs or that the testing services are not reaching them. It's also a fact that they've probably been infected more recently than the other groups, and that their cumulative exposure to testing in numbers of years was less than the other groups. And so these were kind of relative gaps, but we can also look at absolute gaps in testing coverage. And the interesting finding is that even if women in general have higher HIV prevalence as compared to men, the largest group of undiagnosed, with almost 750,000 people, were men aged 35 to 49. So even though they have much lower prevalence, because they are much less likely to be diagnosed, they are a group in absolute number that has the more undiagnosed people living with HIV. We can also look at time from HIV acquisition to diagnosis. So this is a metric that can be interpreted like life expectancy. So for example, life expectancy in South Africa in 2025 is calculated as the age-specific mortality rate in the year 2025. And we assume that if you were born that year and exposed for the rest of your life to those 2025 mortality rate, that you would have a life expectancy of 70, 80, 85 years, whatever the age-specific mortality rates are. So this is what we did here. We assumed that in 2000, we used the testing rate that we observed in 2000, and we assumed that for the rest of your life, you would be subjected to those testing rates. And if that's the case, then it's above, for most countries, it would take an average of 10 years to be diagnosed. So basically when you get an opportunistic infection and you have symptoms and you seek treatment. But that declined through time, especially in Eastern and Southern. With this measure, we can also calculate other metrics, for example, the proportion tested within 1 year, as well as the proportion tested before reaching some level of CD4 cell count threshold. We can also estimate retesting rates and positivity. And what we see on this graph here is the HIV prevalence for the whole region. In yellow, we have the positivity that is decreasing. And here we have the diagnoses yield. So we know that people can be retested multiple times because they don't disclose it to their provider, because they discontinue ART, move to another region, and then they need to be tested again. But we estimated from the model that about 50% of positive tests could be performed on previously diagnosed people living with HIV. People might think that this is necessarily a waste. In some cases, this is a waste, but for example that I gave about people who discontinue treatment and then to be re-engaged, HIV testing is not a waste because we're re-engaging that individual. So in conclusion, for this analysis, we found that in 2020, 12 countries achieved the first 90, but progress was unequal. There was no country that reached the first 90 at that time for all age and sex category. Young people more likely to be undiagnosed. I've talked about men aged 35 to 49. A lot of them are undiagnosed and by definition not virally suppressed. And often these men could have sexual contacts with women that are of a younger age group, so that contributes to onward transmission. We also have challenges with the model, and one of them was that we wanted to understand the impact of changes in testing modality and volume. So this leads to the next presentation, or the next part of the presentation, that were led by Adrien Laurent, who's now at the University of Southampton, but that was also a postdoc in the group. And we sought at that time to review all population-based surveys, because in these surveys, people are asked if they've been ever tested, but then where they tested, where they received their last HIV test. So we tried really hard to come up with a classification, but each survey is a little bit different. So in the end, the only modality that could be reliably estimated from the surveys were testing at ANC. So we sought to understand the importance of that modality for overall HIV. ANC is crucial to prevent vertical transmission, but it's also kind of a low barrier, low threshold modality to access HIV testing. First, because testing at ANC or access to ANC, 80 to 90% of pregnant women will attend at least one visit in the region, and most countries will use an opt-out approach, meaning that by default they will test you for HIV unless you say otherwise. But at the same time, there's been fertility decline and the scale up of new testing modalities. So what was the role of ANC testing in that? So we wanted to understand what are the temporal and geographical trend and the relative importance of ANC testing, as well as the determinants of testing at ANC. So we review all population-based survey with information on testing and testing at ANC. With testing at ANC, the difficulty is that we want to encompass both women who are currently pregnant, but women who also gave birth within the last time period. And we choose for recent testing the last 24 months because some of them had asked the exact month. Some of the survey asked the exact month at which you received the HIV test at ANC, but it differs a little bit by survey. But 24 months was the one that was consistently available, and that's the one we focused on. And then we use a Bayesian mixed effect logistic regression, where we estimated two things: the proportion of women who've been tested in the past 24 months, and then among those tested in the past 24 months, the proportion that tested at ANC. And we were estimating temporal trend to a first-order random walk process, which is kind of a smoother trend, as well as once we obtain the estimates from the model and we want to extrapolate it at the level of the population, we use post-stratification using census and demographical data to obtain. So here you see the result for all countries. In total, we included 139 surveys, so that's 2.2 million women. Here we see the overall graph for the whole region. In gray, it's everyone who's been tested, the proportion of women who's been tested in the last 12 years. In blue is testing outside of ANC, and in red is testing at ANC. So we see that testing in the last 12 months increased from 8% in 2005 to almost 40% in 2021, and that since about 2010, testing at ANC has been stable around just above 10%. The other big pattern that we see, and just move that, is that in countries in eastern and southern part of the continent, recent testing is much higher, and the relative importance of testing at ANC is much smaller than countries in West and Central, where HIV prevalence is lower. So proportionally, ANC testing plays a much bigger role in these West and Central African countries. In terms of determinants, here what we see is the change in the probability of being tested at ANC if you are in different risk group and holding all other covariates constant. So we see that women who are urban, educated, wealthy, multiparous, and older are more likely to have been tested in the past 12 months. So the overall testing programs are inequitable in a way. But among those recently tested, women who live in rural areas, those that are multiparous, adolescent girls and young women, those who have lower educational attainment, lower wealth, are more likely to test at ANC. So even though there's been massive scale-up of ANC testing, it remains an important component, especially in West and Central Africa, and it seems to benefit underserved women as a general rule. So then one of the conclusion from this work was that we should include testing at ANC in Shiny 90, the model that we've developed. And but then we got distracted by the COVID pandemic doing other things, so this was a little bit delayed. But we did it in this part of the work. So this was work by Andrew Kutsi, who's a master's student at McGill. This is work in progress, so comments are welcome. And the idea of this work is that we've witnessed decline in overall HIV testing, the number of tests that were performed since 2018, and we want to understand the impact of that decline. So the peak testing was observed in 2018, so it preceded COVID. It was not something that was caused by the pandemic, but the pandemic did not necessarily help. So the research question that we have was, where does the decline in HIV testing volume occur, and how did it affect HIV positivity? And then the second one, what is the impact of HIV testing decline on two metrics? The knowledge of status, the proportion of people living with HIV who are aware, as well as the time from infection to diagnosis. So the data sources for this are the 2023 spectrum file. As you can see, South Africa is not included because South Africa is not using Spectrum, it's using Tempisa. But there is a shadow Spectrum file for South Africa, so we would like eventually to update that file so that we cannot exclude South Africa, which is a really important country. So that will be a limitation of these preliminary results that I'm going to show you. So if we look at testing at ANC and outside of ANC, in green we have testing outside of ANC. We can see that it peaked in 2018, and there was up until 2021 up to a 25. It varies depending on the assumption that we make, but 25 decline in the volume. So we really see from the period 2005 to almost to 2018, really kind of a linear increase, quite big increase, such that there's almost 90 million tests being performed on an annual basis. And here, we also stratified by testing at ANC. So testing at ANC is in red, and we can see that this modality was not affected by the other one. So that's another reason why we wanted to include ANC testing as a separate modality in Shiny 90, because here if we reduce the overall testing volume, but not at ANC, ANC benefit only women, whereas this benefits both gender. So it could distort a little bit our estimates of knowledge of status. I must say, make a small parenthesis and say that in Shiny 90, we've always encouraged countries to input sex disaggregated data on the total number of tests and the number of positive tests, but very few countries do it. So including ANC, which is performed for women, will kind of mitigate a little bit that limitation that some countries do not enter the sex disaggregated program data. So then that's the question. We also have this map that shows the decline, and the decline is primarily concentrated in these Eastern and Southern African countries, but we also have Cote d'Ivoire, Burkina Faso that have small decline. And if we had a decline in testing outside of ANC, but that we're just switching to higher yield strategies, so strategies that will maximize the positivity or the yield of new diagnoses. Maybe these decline will not have a big impact on the proportion aware or the time to diagnosis. So here we see, and here the x-axis has changed. It's no longer from 2015 to 2023, it's from 2018, which was the peak, to 2023. And we can see that the positivity declined, sorry, the number of positive tests declined by almost the same proportion as the overall, so 23% decrease. And that positivity at ANC was rather, sorry, number of positive tests was also declining. Now, if we look at positivity, there was a small increase by maybe 0.5 percentage point during the period of the decline, but then it reached stable, whereas for positivity at ANC, it quite declined. So is there evidence for big efficiency gain? I'm not quite sure, but this is ongoing work that we are doing and trying to really understand, because so far, Shiny 90, the model, does not distinguish between testing modality, except ANC that I'm gonna present, and that's one of the limitation of the model. So if we want to estimate the impact of that decline, assuming that there was not a switch to higher yield strategy, what we can do is, here we have the decline in ANC testing, and then we just project if rates that were observed at the peak number of tests, the year in which there was a peak number of tests, were projected forward, what would have been the impact on the model output? And you can see that it's increasing because the population denominator, so the overall population, is also increasing during those years. So even though the rate should be flat, the increase that we see here is due to population growth. So basically, what's the impact on the proportion of people living with HIV aware? Here we have the impact on men, the impact on women. We can see that it's very small, 1%, 2% for men, 1% for women. And this graph basically is just the difference between these two curves. So we can see here the 2% decline and 1% decline. So we can interpret that as, had there's been no decline in the number of HIV tests during those periods, proportion of people living with HIV could have been 1 or 2% higher. Of course, this is not a metric that is super sensitive to change in testing volume, because let's say that we stop completely HIV testing today, we don't undiagnose people. All the people who are aware of their status will remain aware. However, it's the new infection, the new HIV acquisition that will not be affected. So to kind of look at using a cross-sectional measure, we looked at the impact on time to diagnosis. Again, this is estimated as life expectancy. So if you were subjected for the rest of your life to the testing rate observed in 2021, 2022, 2023, that would be the effect. And what we see here is that the median time to diagnosis increased by 8 months for men and 5 months for women. The reason we hypothesize is that it's mainly due to ANC testing that did not decline. So could have, among women that are sexually active, that are not that are getting pregnant, that there would be increased diagnoses. And then we can look also at geographic heterogeneity. So this is the map with the decline. It's just the same that I've shown before, but we've highlighted the countries that were supported by PEPFAR, because PEPFAR really tried from 2017, 2018 onwards to optimize HIV testing services in those countries. And we see that the big impact that we have on time to diagnosis was mostly in observed in PEPFAR country where we had the biggest decline in total testing both. Conclusion is that HIV status awareness would have been 1 or 2% higher without a decline. Time to diagnosis, which is a more sensitive metric, would have shown that it's 5 to 8 months increase in time to diagnosis. So this is time where people remain infectious, contribute to onward transmission, and that far countries have the largest increase in diagnosis delay, but there was also diagnosis delays in the other countries. The limitation is that beyond the integration of ANC testing in this model, we do not consider how changing testing modalities affect kind of the efficiency of those services, and it's also not stratified by key population. The strength is that the model is fully aligned with the UNAIDS indicators, such that we have consistent estimate of incidence, mortality, etc. So kind of the conclusion is that prompt diagnosis is critical. It reduces onward transmission. But from this data, it's difficult to say how best to optimize HIV testing services, and it's likely context specific. So again, this is preliminary work, ongoing work, and we want to refine some of those hypotheses that we made. Last part of the presentation is the integration of another testing modality into Shiny 9D spectrum to estimate diagnosis coverage, and it's that of HIV self-testing. HIV self-testing, again, this is work in progress led by Aishi Arajuka, a master student at McGill, and the main have with HIV self-testing is that the scale-up of this new testing modality could render the interpretation of the Shiny 9D mathematical model of the program data obsolete, because not all distributed tests will be used. And also, it's important to remember that if I take an HIV self-test and it's reactive, it's not confirmed as a definite positive. I need to seek confirmatory testing. So what we will have in the program data is that these tests will not appear in the overall number of tests being distributed or being administered, but those that have a reactive self-test will appear as positive tests. So it will render, really distort our appreciation of the testing data. So here we wanted to triangulate survey and program data across country to understand the key characteristic of HIV self-testing. And the question that we have is that what are the age and sex-specific trends in the uptake of HIV self-tests, and also what are the proportion of HIV self-tests that are being used, and also who uses them using broad demographic category. So we review all survey again that have population data. In total, we have 46 surveys with information that we were included. And we also reviewed program data on the number of HIV self-tests that are being distributed. And for that, we looked at the spectrum file in UNAIDS, but not all countries use it. But it's also reported to GAM, so we've looked at GAM or otherwise PEPFAR to come up with the most years of data that we have for HIV self-testing. Now, we did not use Spectrum EPP for that one because we wanted to really simplify it because we don't have a lot of data for HIV self-testing. So we just wanted to look, without thinking about HIV status, without thinking about other modalities, who has ever used an HIV self-test. So basically, it's kind of a mathematical model with two compartments. One, those that have never used, and then those that have ever used an HIV self-test. We also assume that there could be, if you've ever used an HIV self-test, that you could be more likely to use it again. And that's based, for example, in some countries where you could have a program of HIV self-test distribution to specific key population. And therefore, once they receive it and they like using it, they could be more likely to use it again. And the model is stratified by sex and also by 4 age groups. And these are just like a simplified equation. I won't go into detail about them. But the general idea is that we can also fit the model to the proportion of people who've ever used an HIV self-test from the survey, and also from the program data, the number of HIV self-tests that are being distributed. Oh, I forgot to mention, we did not use, like I said, we did not use Shiny 90 because Shiny 90 fits or estimate the parameters independently for each country. So what happens in country X does not impact what's happening in country Y. Because we're in a really data sparse setting here, we didn't want to use that, and we wanted to be able to pool information to borrow strength. So that's why we're using a hierarchical model of HIV. So why a hierarchical model? It's to borrow strength. And what we use are random effect, and it's a really similar idea between a fixed effect versus a random effect meta-analysis, if you're more familiar with that. So just to explain very quickly, we have country A that has 5 data points, so quite a good estimation. There's not a lot of uncertainty in that parameter. We have another country with very few data points, a lot of uncertainty, and then a country C, something in the middle. If we were to estimate each country differently, let's say the mean of these distributions, have something like that. So that would be the mean of the country A, the mean of country C, the mean of country B. When we're using a random effect, what we're doing is that these come from an underlying distribution, an overall distribution for that parameter. And that means that we also estimate an overall distribution, and then we have what's called shrinkage. So because here, this parameter had a wide uncertainty around it, and will not precisely estimate, it shrinks towards the overall distribution. This one, even if it's an outlier, because it has a lot of data, the amount of shrinkage is very little, because there's a lot of data here. And this is kind of an intermediate setting where we're not too far off, so it's not too much an outlier, and we are having reasonable uncertainty. So the general idea of the model that we've developed is that we can pool some of that information, not necessarily about trend, but about testing ratios for male, versus female, the age group, etc. And also, if a country does not have any data to inform a specific parameter, we can inform it by the overall distribution. So this is an example of the model. So we've used the parameters that we're estimating are the fraction of distributed HIV self-testing kits that are used, the male to female rate ratio, the rate ratio by age, the retesting rate ratio for HIV self-testing. And we assume for simplicity that all of the above are time invariant. We calibrated to population-based surveys and to program data. And this is an example of a fit for Eswatini, where we see the 2 surveys, male and female. This is the proportion of people in Eswatini who've ever used an HIV self-test, so just around 30%. And here we have the program data that is estimated. So as you can see, we don't have program data before 2017, but otherwise we get kind of good overlap. And then for 2024, we don't have data, so that's why we have this huge uncertainty, and that uncertainty that fans out here. So this is the overall fit, but we also by age and sex. We're assuming that the age rate ratio are the same between sex, but we could simplify that. So in terms of overall uptake, it's about 6% in 2024, slightly higher above for men, and there are huge regional differences. It's only 2% in West and Central African countries, whereas it's 10% in Eastern and Southern African countries. Again, South Africa is not included, which has a big population that could affect the estimates. If we looked at the uptake by age group, the people who are, the referent here is people who are 15 to 24. People who are 25 to 34 are the more likely to use an HIV self-test. And we estimate a rate ratio for those who are 50 plus, but as you can see, there is only 1, 2, 3, 4, 5 surveys that have this information. So that's why you have all this similarity in the other one. But again, it's the advantage of the hierarchical model is that we can inform the parameters for these other countries. This is just another way to look at it in absolute terms instead of rate ratios. We can see that 25-34 more likely than the 35-49, 15-24, and 50 plus. If we're thinking about the male to female rate ratio, now this is a setting where we have a lot of information because this comes directly from the survey data, and there's no information on the program data. It's just the overall number of testing of HIV self-test being distributed. However, there's a really high heterogeneity. Some countries, men are less likely to use it. Other countries, men are more likely to use it. But on average, the overall, men are slightly likely to use it. A limitation also is that I've said that the rate ratio are time invariant, so we assume that it's the same rate ratio in 2010 versus 2023. And for some survey, we see a reversal of the estimates from the survey. So at time 2015, men will be more likely to use an HIV self-test, and then they will be less likely in the other one. So again, I don't think we can. There's a lot of information to have time varying rate ratio, but this is something that we kind of see. The retesting rate ratio, this is something that's informed by the triangulation and survey and program data. There's no information solely in the survey or solely in the program data. It's really when we combine both that we're able to estimate. And you can see that for most countries, it defaults to the overall or the prior, that there's only a few countries, Fratini, Lesotho, Malawi, and Malawi that have information. There's also a very high uncertainty. Basically, this is the model fit, and basically the way that we can estimate it for in this country is based on the increase. If there's more, does that mean that I need to stop?
No, you've got 7 more minutes.
Okay, I'll go quickly over it. But basically, the idea is that we can estimate the rate ratio based on the increase in the number of tests from one survey to the other. For the proportion of tests that are being distributed, it's also informed by the triangulation. Here we have a little bit more information, but there's also a wide uncertainty. And overall, it's probably 70% of kits that. Again, to be able to estimate it, we need to have overlap between the survey data point and the program data to be able to estimate it. So if, for example, we have no program data to the year that was estimated, which is that for most countries, it defaults to the prior. So in conclusion, HIV self-testing is no longer a marginal testing modality overall, with about 6% of the population have ever used it. It's higher in Eastern and Southern than Western and Central Africa. The limitation is that we rely on self-reported estimate. Even though we've tried to use a hierarchical model, we still obtain very imprecise estimates for some parameter, retesting proportion of kits used. Strength, we triangulate all the evidence available using a hierarchical model. And in conclusion, we need to understand the impact of the scale-up of HIV self-testing on diagnosis gap, and by incorporating this modality, because otherwise I think that in the years ahead we might, the interpretation of the program data by the model will be biased. So in summary, where we are, measuring HIV knowledge of status is not easy. Shiny 90 was developed in 2018. Many things have changed since then, and the incorporation of these new testing modality is probably warranted. Where should we be going? And the fact that the US will no longer fund big surveys, such as the demographic and health surveys, or support countries, for example, by the CDC, if it's unclear how many new fields there will be in the years ahead, we will need to rely more on program data. So it will be really important to maintain and increase their quality and completeness. As we saw, just trying to find information on the number of HIV self-test kits being distributed was difficult. I showed you a couple of examples where we had good data, but there's for some countries we only have 2 years of program data for the last 2 years on the number of HIV self-testing distributed. And thinking ahead, also there are questions about which metric we should use to monitor diagnosis gap, because we have an aging HIV epidemic, people are diagnosed, and the proportion, just looking at the proportion of PLA-HIV aware of their status, it's not super sensitive to declines in HIV testing because you don't undiagnose people. So should we focus more on metrics of testing efficiency, such as time to diagnosis? And more generally, in the face of funding constraint, the potential cuts to the PEPFAR program, it could be easy to just decrease the amount of HIV testing that is being done. But we need to understand the long-term impact of these changes in the testing strategies. I think, of course, in the short term, you don't want to take people off ART, but it's also important to continue to link people newly acquired or that disengage from care to HIV. So I don't have detailed answers on that, but these are just questions that I asked myself. So thank you. Sorry, I went a little bit too long.
Thanks very much, Mathieu. That was excellent. We are almost at time, but are there any questions that people want to ask, including people online? I don't know if there's any burning questions people have. Krishna?
Thanks for that. Very interesting. I'm curious that you had a very sudden drop in testing volumes, like peaks and it goes down.
Testing programs are quite expensive. They're not cheap. And when you have reached high levels of diagnosis coverage, people might question why you're devoting so much resources to test 90 million people. So there was a shift in testing strategies to try to be more geared toward higher yield testing strategies, so index testing, etc. The problem with index testing is that if you don't find any new HIV positive that have never been diagnosed before, you cannot test their partners. So there could be potential for a lot of just retesting. So it's mainly due to that, and I think it's also due to the policy that we've seen that this decline was more pronounced in PEPFAR countries. So it's donors that have suggested to change the testing strategies.
Yeah, it was a very strongly PEPFAR-driven move in a lot of countries.
Any other questions?
Or just a comment about the self-testing estimates for your colleague. 2 of those 3 countries are tiny little countries, Eswatini and Lesotho.
Yeah.
As long as she's aware of that.
Yeah.
It's hard to draw conclusions for the whole of Africa based on such a thing.
So for these are weighted by population size.
Okay.
So if there's only 1 million in one country that we estimate that testing coverage is 40%, these get downweighted a lot when we take into account the population denominator. However, it is true that when we use kind of these graphs, then we don't weigh by the size of the country. It's just by the precision of the estimates that will influence it. So if, for example, in Lesotho or Eswatini, there are small countries, the proportion of self-test kits that are, or the retesting ratio is very different than the other, it affects the overall one quite a lot. But still think that it's the correct approach to use.
I mean, I appreciate there's very little else to use.
Yeah. And if we want to include it, so that's one of the reasons that we've tried to estimate using a really simple model the parameters so that we could, when we're going to integrate that in Shiny 90, have better priors for countries that do not have any data to inform those parameters. But what we found out is that there's actually not a lot of data, even when we pull everything together.
Okay, thanks everyone. We are at time, so I think we must close now. Mathieu is going to be around for the next 2 weeks, so if you've got any further questions or comments, please do catch him when you see him in the passage or email him. Thanks everyone who's joined online as well. And thank you, Mathieu, for presenting.
Yeah, if there are questions online, I can put it to the chat. I can spend a minute or two answering.
Great.
Otherwise, thank you.
Thanks everyone.
Thank you.